Okay, how's everybody doing? Are we all awake? You're sure now? Okay, roll those shoulders, give them a little shake, have a glass of water, because now we're going to tackle drugs. If you remember from yesterday, we mentioned in the overview that drug regimen review has not changed for us in OASIS D. But this measure, this query, is new in the other settings. So as traumatic as getting accustomed to the J and GG questions that were new to us, it has been just as difficult for the other settings to figure out how they were going to work with the drug regimen review and the follow-up in their settings. So take a little comfort as we go through this one, knowing that we've had some time to get used to it, and it's something that has been a part of our lives from the beginning. So we do have a good handle on this, and as I go through, I'm going to try to remember to answer some of the questions that we've received over the past few months on this topic, and try to get them clear so that you will have a better comfort level with any remaining questions or uncertainties you might have had. That said, we're going to slide right on by those acronyms because you have them here, they're your dictionary, and you'll always be able to find them if you need them. Our objectives for this piece of the presentations today is to understand the cross-setting alignment that goes with drug regimen review 2001, 2003, and 2005. We're going to summarize the intent, the coding instructions, and the definitions for these three items. Then we're going to practice applying the instructions so that we can accurately code the practice scenarios, and we will be able, as a takeaway, to really understand and describe the drug regimen review quality measure. Because when you go back, as part of any update, refresher, training activity with your staff, understanding how to teach it to them and to describe to them what the measure really means and why we're asking them to go through this exercise is really very important. We have the same information again about the Drug Regimen Review Quality Measure and the Impact Act. This measure is an assessment-based, cross-setting process quality measure. Cross-setting, remembering that this is new for the other settings. This is adopted to meet the requirements of the Impact Act for medication reconciliation. This is important because if you remember from yesterday, we talked about the fact that one of the most common reasons for emergency care or readmissions is an issue with medications. Either an error, a reaction, a side effect, but it is medication related. So this is a critical issue for making sure this gets done correctly. Part of this is to assess whether the agencies are responding to potential or actual clinically significant medication issues when they are identified. The OASIS items 2000, 2002, and 2004 were the foundation items for the drug regimen review measure because none of the other settings had items or measures addressing this. So the changes were made to develop standardized items for use across the settings, and that gave us 2001, 2003, and 2005. This measure is now across the PAC settings, and the dates for the implementation, and for us, our most recent revision in January of 17, are here, so that you can see last year in 2018, long-term care hospitals, SNFs, and IRFs, they had to acquire this measure and implement it, while we had to just deal this time with the revisions. 3 conditions need to be met for this care episode to have a favorable measure result. 2001, the completion of a drug regimen review at the beginning of the episode, start of care, resumption of care. 2003, the physician contact and follow-up if a medication issue is identified at Sock or Rock. 2005, physician contact and follow-up each time a significant medication issue is identified throughout the entire care episode. When we go through this, we will clarify there were questions that came in, particularly about 2003 and 5. This is here the data collection items 2001 and 2003. You can see them on your screen. I know the print is a bit small, but it's a small query, so it blew up a little better than some of them do. And this gives you the ability to look at what you're going to see in the tool when you are using it. Here's 2005. This element is completed at transfer to inpatient, death at home, and discharge from the agency not to an inpatient facility. Remembering that 2005 asks you to go back and look through the entire episode of care. The definitions are critical to understanding how to fill this measure. Drug regimen review in post-acute care is considered to include the following: to identify and, if possible, to prevent clinically significant medication issues. That's a tricky phrase, and we're going to look at that as we go through, because this requires sound clinical judgment. Medication reconciliation, review of all medications a patient is currently using, and a review of the drug regimen, which is the schedule, the timing, and the structure of how the patient is going to take these medications. Drug regimen review includes all medications, prescribed and over-the-counter, administered by any route, and it does, as a point of clarification, it does include TPN and oxygen, so that you must have those on there. Oxygen use is considered a medication. When we talk about including in the drug regimen review, prescribed and over-the-counter, I had such a head-on collision with over-the-counter medications in my own life that I really do need to explain how critically important this can be. I know someone, a young woman, who was going through chemotherapy for Hodgkin's disease. Chemotherapy has lots of difficult side effects. It was a large center, and so they grouped, whenever possible, their patients so they were receiving treatment on the same day with other people in their own age group. So this person was really having difficulty with certain side effects with her fatigue level and just total disinterest in the world around her. The young lady sitting next to her said, "I'm taking ginkgo biloba, and let me tell you, take some of that, take some St. John's wort, you're going to feel 1,000% better." Okay, so she did, but she never told the nurse that was assigned to her, and in her next doctor's appointment, she didn't tell the doctor either. But her lab work caused an extraordinary flap. They brought her in. What is wrong? What are you doing? How are you feeling? What's different? Because your lab work took a nosedive. Ginkgo biloba, St. John's wort, they didn't mix with her chemotherapy package at all. But she didn't tell anyone about the over-the-counter medications she had added to her own regimen, and as a result, suffered a 3-week very negative setback. These things can happen. It can happen to your basic diabetic patient, your basic cardiac patient. You really need to know what they are taking, because it may affect their fluid balance. It can affect any number of things. So you really want to know what they've been visiting in the vitamin aisle, because it does make a big difference. And I would guarantee you the physician does not know what they've been supplementing with that their neighbor recommended. You laugh, but I'm telling you, I lived through that one. It was not pretty. Clinically significant medication issue. This phrase we will hear over and over in this presentation. What is a clinically significant medication issue? A potential or actual issue that in the clinician's professional judgment warrants physician or physician designee communication and completion of the prescribed or recommended actions by midnight of the next calendar day at the latest. So the decision is made based on the clinical judgment and based on patient-specific circumstances. This is where you really need to have a good comfort level in the clinical judgment of your nursing and therapy staff. If you don't have that comfort level, now is the time for really good staff education on medication issues. Here's a list of some of those potential or actual clinically significant medication issues. Adverse reactions, rashes, itching, ineffective therapy, such as an analgesic that does not actually reduce the patient's pain. Remember, pain is as much perceived as real. And so you really want to be looking at a full assessment of pain. What about side effects? Potential bleeding from an anticoagulant. I know people today watch less and less commercial television, more and more of streamed material. I had a patient tell a nurse when they were going through the medication regimen, I stopped taking that Prevacid. And my husband stopped taking his Prilosec. We can't take that. And the nurse said, why not? You've been taking it for weeks and weeks. They said, because on the TV last night, they said, don't take this if you're taking an anticoagulant such as warfarin or Coumadin. And I'm taking Plavix, and they told me it was the same thing. So I can't take those anymore. But he had terrible agita, and they never called the doctor to say they stopped this medication. Asking these questions, verifying what you're doing on every visit is how you get the right information to answer these questions clearly and determine if there's a clinically significant medication issue. Drug interactions, such as drug to drug, drug to food, and drug to disease interactions. Watch those citrus foods with the antibiotics. What about duplication? How many times have we done a med rec, a drug regimen review? Patient comes home from the inpatient setting, clutching a script in their hand for Toprol. And they get home and they look at the kitchen table and there's the low pressor. That's not the same thing. Those are two different names. I'm going to take them both. And in 2 days, they pass out cold on the floor when they go to stand up. That is clinically significant, the potential risk. And that's on us to make sure that we are looking for duplicate therapies. What about omissions? What about looking at what the patient was taking before the inpatient stay, what the physician thinks they're supposed to be taking, what's in the house, what's on the referral information? You need to be looking at all of those lined up for omissions and duplications to be sure that the prescribed regimen is accurate and correct at the end. Dosage errors. It's rare, but pharmacy errors occur. Many, if they occur, the ones I've seen have actually been typos on the labels. The drug in the bottle is correct, but the label is mistyped. Watch what you've got. You can get drug apps, medication books, pharmacy books as an app right for the infamous cell phones, everything. There's no reason for us not to have the information right at hand. And lastly, the most significant of all, I think, is non-adherence, either on purpose or by accident. Any one of these must reach a level of significance that warrants notification of the physician or designee for orders or recommendations by midnight of the next calendar day at the latest. A circumstance that does not require this immediate attention is something not considered to be potential or actual clinically significant medication issue for the purpose of this item. This is all coming down to clinician judgment on how significant it is, and that's only going to be based on how thorough the assessment was. Here are some examples of what might be a potential or actual clinically significant issue. Mr. A's list of medications from the inpatient facility discharge instructions do not match the medications he shows the clinician during the assessment visit. Mrs. W is confused about when and how to take her medications, which indicates a high risk for medication errors. Mr. T indicates he will not take his prescribed medications because of financial reasons. Additional examples can be found in Section L in the guidance manual. Drug regimen review is a part of the comprehensive patient assessment. The comprehensive assessment is the responsibility and must ultimately be completed by one clinician, but collaboration is allowed. Agency policy and practice determine this process and how it is documented. More and more, we are doing therapy-only cases. I see the heads nodding already. This is where you need to think clearly and carefully about how you're going to do drug regimen review, and you need to consult your own individual state's practice standards for each discipline. The scope of practice, according to your state law, is where you will be able to get the backup for who can do medication reconciliation as opposed to the full drug regimen review. And that's where you need to look for it, and then you need to do whatever you need to do to codify that in policy and documentation practice. That's the reason why we're not going into who can or cannot do what pieces. It varies from state to state by discipline, so you need to research that. If portions of the drug regimen review are completed by agency staff other than the clinician responsible for completing the SOC-ROC OASIS, information on the drug regimen review findings must be communicated to the assessing clinician responsible for the assessment so that the appropriate responses can be entered. The MU90 assessment date completed will indicate the last day the clinician responsible for the assessment gathered or received any input used to complete the comprehensive assessment document, including the OASIS items. Okay, does everybody understand that? What you put on the M90 block. Okay, in the provider Q&A, we have here, with the expanded one clinician convention, would it be appropriate if a second clinician completed the drug regimen review in its entirety by phone and collaborated with the assessing clinician to respond to 2001 and 2003? Before we read the answer, how many think you could do that? How many people think you could do that? And how would you would be able to document? Nobody. While the expanded one clinician convention allows a second clinician to complete the drug regimen review in its entirety and collaborate with the assessing clinician, it is expected that an in-person assessment would be included as appropriate in the process. While portions of the drug regimen review may be conducted over the phone and/or by a clinician in the office, evaluating the medication list to assist with reconciling discrepancies, other portions of drug regimen review would require in-person assessment, such as evaluating the patient for the effectiveness of the medication, particularly pain medications, for the presence of any significant side effects. You really can't evaluate a rash over the phone. The assessment must be completed within the required time frame, and all requirements for the collaboration must be met. Let's talk about that contact with the physician or designee. It is here where the difficulties really begin to multiply. And the heads are nodding again. Communication to the physician or physician designee to convey this identified potential or actual clinically significant issue. This has to be a two-way street in some fashion. A response from the physician or the physician designee to acknowledge the receipt of the information and or convey prescribed or recommended actions in response to the issue that you've identified. This is a two-way street. Both sides must actually occur in order for you to answer the question properly. So how do we reach out to the physicians and their designees these days? We have so many more options than we used to have. Perhaps you are fortunate enough that you're able to catch them in person, speak to them by phone, use voicemail. There are other electronic means and fax and any other means that you use that appropriately conveys the message of the patient's actual status. But these communication methods must be a two-way street. You can reach out to the physician directly, speaking directly to the physician or the physician designee, referring to APRNs, PAs, and again, scope of practice. It's critical that you know what the scope of practice for those disciplines is in terms of how much latitude they have. And that's something that varies state by state, and you're going to need to research that. Indirectly, the physician's office staff may take the information for the physician, and this is also needs to be looked at within the legal scope of practice. Let's talk about the follow-up piece. So you've identified that clinically significant medication issue. You've called and you've spoken to the front desk person who promises the information is going right to the PA. Now what? The process of contacting the physician or designee to communicate the identified medication issue, and to the extent possible, completing all physician or physician designee prescribed and recommended actions by midnight of the next calendar day at the latest. There's a key phrase in here. That completion of the follow-up to the extent possible, meaning if you've identified that significant issue, you've called the physician, and the physician gives you orders that extend out over 3 days. As long as you've completed the portion that can be completed by midnight of the next calendar day, and you have the explicit instructions for going forward, then you've done the two-way communication and the follow-up. Let's look at the guidance and do a little practicing. Let's talk again about the coding and who can do this. No specific discipline is identified as exclusively able to perform this assessment. According to federal guidelines, only registered nurses, physical therapists, occupational therapists, and language pathologists are qualified to perform the comprehensive assessments and collect OASIS data. But as I've said, states may have more stringent guidance, and state-specific queries should be addressed to your appropriate state agency so that you can locate the scope of practice for each of those disciplines and identify what, if any, limitations there may be, so that what you put in place in policy and in practice will be compliant in both ways. Here's the question, 2001. Did a complete drug regimen review identify potential or actual clinically significant medication issues? You have three choices. No, there were no issues found during the review. Yes, issues were found during the review, or not applicable, the patient is not taking any medications. Now, how often does that happen? Most of them have a list that's 20 items long, right? And I'm not answering if anybody asks me what mine looks like. I'm going to take the fifth. Coding instructions. You're going to code this as 0, no. No issues found during review if based on the assessing clinician's professional judgment, no potential or actual clinically significant issues have been identified. You will code this as a yes, issues found during review, if the drug regimen review conducted during SOC or ROC, based on the assessing clinician's professional judgment, a potential or actual clinically significant medication issue was identified. You will code it 9, not applicable. The patient is not taking any medications. If, in fact, a drug regimen review indicated there were no medications prescribed and the patient is not taking any medications by any route at the time of the assessment. And that means you could go out there with referral information, ask them if they're taking any medications, and they say absolutely not. And look over at the kitchen table, and what do my eyes find? I find vitamin E and vitamin C and St. John's wort and heaven knows what all else. So now you need to find out if they're taking those because, in fact, they are taking medications over the counter. And you will need to inform the physician of that so that judgment and instructions can be handled. What about skip patterns? Skip patterns pop up everywhere. If we have coded 0, no on 2001, you are going to go directly to 2010, patient caregiver high-risk drug education. If you've coded it yes, issues were found, you're going to move directly to 2003 for the follow-up. If you've coded it 9, patient is not taking any medications, and you're absolutely sure that this is true, you are now going to 2102, types and sources of assistance, which we discussed yesterday. So where are you getting this information about what medications they're taking, what they should be taking, what's in the shoebox or the brown paper bag under the bed? And believe me, I've actually seen those come out. Patient assessment is critical. It involves all the questions that you need to be asking of the patient and the caregiver. The home health COPs will give you some guidance about the complete patient assessment and the care coordination, which will help to guide you in gathering information. Clinical record itself, including communication notes, the medication list or profile, and any other orders that may have come in the recent past. Collaborating with other agency staff as is allowed, including a review of their documentation and any other information that you can get from them. And finally, you can always consult the CMS OASIS Q&As as they relate to drug regimen review. Okay, now it's time to make sure that everybody's awake. Get your phones out. We're going to practice coding in this scenario. 2001. During the comprehensive assessment visit to Mr. K, the PT, physical therapist, reviews all the patient's medications and identifies no problems, except the patient's newly prescribed pain medication is not in the home. The wife, Nancy, states they were only going to pick it up from the pharmacy if the pain got bad enough. Yeah. The PT reviews the physician's instructions for the new medication with Mr. K and with Nancy. They agree the medication should be on hand and to follow the physician instructions for administration. Prior to the physical therapist leaving the home, the wife has gone to the pharmacy and returned with the medication. So, Did a complete drug regimen review identify potential clinically significant medication issues? Select your answer. A, no, no issues found. B, yes, issues were found. C, 9, not applicable, not taking any medications. Or D, enter a dash. Oh, look at that. We're in a dead heat here. Think it through. All right, let's go back to our slides and see what the real answer is. Look at that. No issues were found during the review. Okay, those of you who thought that there were issues, let's take a look now at the rationale behind this. The coding was no issues found during the review because the issue in the physical therapist's professional judgment did not require physician or physician designee contact by midnight of the next calendar day, and therefore it does not meet the criteria for a clinically significant medication issue. Because the wife went out, purchased the pain medication, brought it back in, and it was physically present in the home, and the patient and the wife had agreed to follow the instructions. Therefore, during the course of the visit, the issue was totally resolved and did not require any intervention from the physician because he'd agreed to follow the instructions. So that's the reason why. And it's not surprising to me that this was a 50-50 split, because it's confusing. Well, there was an issue, she didn't have the pain medication, but it was completely resolved without a need for the physician intervention. Let's look at another one. During the start of care comprehensive assessment, Nurse Richard completes all elements of the drug regimen review except for checking for drug-drug interactions. Okay. Did a complete drug regimen review identify potential clinically significant medication issues? Using your phone or your laptop, select from A, no issues found during the review. Yes, issues were found. 9, not applicable, the patient is not taking any medications. Or enter a dash. It looks like the majority are leaning toward entering the dash, that there was no information. Let's go back to the slides and see if they were right. In this case, did a complete drug regimen review identify potential clinically significant medication issues? And the answer is enter the dash because there wasn't enough information. When an element is not assessed, the drug regimen review is considered incomplete, and so you would need to enter the dash there. However, editorial comment? Yeah, I hear the rumblings in the room, and I can practically hear them coming in over the internet. Really? This is a clinician who did not check for drug-to-drug interaction? I sense a little remediation coming, yes? Let's look at 2003, the medication follow-up. The intent of this item is to identify if the potential or actual clinically significant issues that were identified through the drug regimen review were communicated to the physician or the designee, and to the extent possible, prescribed or recommended actions were completed by midnight of the next calendar day following their identification. So for each potential or actual clinically significant medication issue that was identified, you need to identify if the physician or designee was contacted and the prescribed or recommended actions were completed by midnight of the next calendar day at the latest, bearing in mind to the extent possible. Many times the orders you get extend over several days. Here are some examples of by midnight the next calendar day. A clinically significant medication issue is identified at 10 a.m. on February 12th. The physician or designee, the prescribed recommended action is completed on or before 11:59 on February 13th. So in that case, the issue was identified and the actions completed. A clinically significant medication issue is identified at 10 p.m. on February 12th. The physician or designee's prescribed or recommended action is completed on or before 11:59 p.m. on February 13th. So that you have the time frame, you know what your time span is. And bearing in mind always that the actions recommended or prescribed are completed to the extent possible. You're going to code this one 0 or no if all potential or actual clinically significant medication issues were not communicated to the physician or designee with the prescribed or recommended actions completed to the extent possible by midnight of the next day. You will code it yes if the two-way communication and the completion of the actions occurred by midnight of the next calendar day after the issue was identified. A dash is a valid response for this item, but it should be a rare occurrence. You would code the item 0 or no if all potential or actual significant medication issues were not communicated to the physician or designee with the actions completed to the extent possible by midnight of the next day. Some examples might be where the clinician did not communicate all of the significant issues to the physician or designee until after midnight of the next calendar day. They got busy. That's what they'll tell you. Oh, forgot. I'll get to it. Clinician communicated all issues to the physician or designee, but did not receive a response until after midnight of the next calendar day. This is the most common issue. Yes, I say all the heads are going up and down. Yes. It is still critically important that we get the information to the physician or designee and that we find a mechanism, whatever it might be, for the two-way communication to actually be completed between your clinician and the physician or designee they are trying to work with. And as unfair as it may seem, this is still our responsibility. We are the clinician caring for the patient. We're the ones in the home, and we need to ensure that this two-way communication does in fact occur. You code this yes if the two-way communication and completion of the recommended actions to the extent possible has occurred by midnight of the next calendar day after the issue was identified. So the examples here are that the clinician has communicated all identified issues and all the actions for the identified issues were completed by midnight of the next day. A second example might be that the clinician contacted the physician or designee regarding all of the issues identified, and the physician or designee communicated that no actions were necessary. As long as all the communications back and forth, the two-way communication, took place before midnight of the next calendar day, you are going to code this yes. Okay. If the two-way communication and completion of the actions occurred by midnight of the next calendar day, you're coding this yes. Now again, an additional example here, and this does happen. The physician or designee recommends an action that will take longer than the allowed time to complete. The agency has taken whatever actions possible to comply by midnight of the next calendar day. For example, the physician order for interventions followed by monitoring the nurse the issue over the weekend and then call again if there's a problem. Or the physician instructs the patient to address the concern with his primary care physician because you've got to visit there in 2 days and, just take it up with him. That is a recommendation. The other is an order, and either one of them does give you the two-way communication, and the activity has been completed to the extent possible before midnight of the next day. Again, for 2003, the resources where we can find the answer to our questions. Where are we going to look for this data? In the clinical record, in the communication notes between different members of the care team and the physician or designee, the patient's plan of care, and the medication list or medication profile, whatever term you use, you should be keeping that as current and updated as it possibly can be. Okay, let's do a little practice coding here for 2003. During the start of care comprehensive assessment visit, the RN completes the drug regimen review and identifies that the patient is taking 2 antihypertensives, one newly prescribed during his hospital stay, and another he was taking prior to his hospitalization. We see this frequently. During the home visit, the RN contacts the physician's office and leaves a message with the office staff, providing the notification of the duplication and a request for clarification. The next day, the RN returns to the home to complete the comprehensive assessment and again contacts the physician from the patient's home. The physician office nurse reports to the agency and the patient. The physician would like the patient to continue with only the new prescribed antihypertensive and discontinue the previous medication. Okay, for 2003, did a complete drug regimen review identify potential clinically significant medication issues? Using your phone or your tablet, select from A, no issues were found, yes, issues were found, 9, not applicable, the patient is not taking any, or enter a dash. Look at that, 100%, good job. Let's move on to the slide. And you'll see that you were all correct. An issue was found. Let's look at the second half of this. Did the agency contact a physician or designee by midnight of the next calendar day and complete the prescribed recommended action in response to the potentially significant issue? Let's pick an answer for this one on your phone or your tablet. Is it A, no, B, yes, or a dash? Let's see what we have. 97%, only 2% think that it was a no. All right, let's go back and see what the slide tells us. The answer is yes, because the nurse did make a second call, but we are still dealing with the same time period. It did not extend beyond. She was able to get an order back and complete that action in the time frame. One more time. This is the rationale. We code 2001 yes, the issue was found, and 2003 as yes, it was resolved. It was communicated, and the action was taken before midnight of the next day. That brings us to the third question in drug regimen review, 2005, medication intervention. The intent of this item is to identify if a potential or actual clinically significant medication issue that was identified at the time or any time since the most recent SOC rock. So we are looking at the whole episode here. Were these communicated to the physician or designee, and to the extent possible, were the prescribed or recommended actions completed by midnight of the next calendar day following that identification? So are we all clear? 2005 is not talking about an isolated incident. This is talking about you going and looking at the whole episode in its entirety. M2005 includes looking from the time of the patient's transfer, discharge, or death back to and including the most recent start or resumption of care. That was one of the questions that we did see coming in. Many people were confused, thinking that, well, I resolved the first one at the start or resumption, and there haven't been any more since, so I'm going to say no, there weren't any. But this is clearly explaining that this includes the sock rock visit itself, and then from there all the way to the transfer, discharge, or death. So the specific instructions are that the assessing clinician, alone or in collaboration with other agency staff, reviews the patient's clinical record back to and including the most recent start or resumption of care to determine if for each clinically significant medication issue identified, the communication occurred and, to the extent possible, the prescribed or recommended actions were completed by midnight of the next calendar day. So for this item, you are going to code this no if all the clinically significant medication issues identified at the start rock or any time since were not communicated to the physician or designee, and all the prescribed actions were not completed to the extent possible by midnight of the next calendar day. You can code this yes if all the issues identified at the sock rock or any time since then, if the physician was notified and the prescribed or recommended actions were completed within the appropriate time frame. You would code this not applicable if there were no issues identified and the patient is not taking any medications prescribed or over the counter from the sock rock or at any time during the episode. A dash is a valid response, but clearly it should be a very rare occurrence, given that it is a part of the clinician's responsibility to conduct and respond to the complete assessment. You would code it 0 no if all clinically significant issues identified were not communicated to the physician and the actions not completed in the time frame. Here are some examples to make it a little clearer. At the time of or any time since the most recent start or resumption of care, the clinician did not communicate all the identified issues to the physician until after midnight of the next day. The clinician communicated the issues to the physician or designee, but did not receive a response until after midnight of the next day. And finally, the clinician did not complete all the physician or physician designee prescribed or recommended actions by midnight of the next day to the extent that is possible. Oh, that didn't move. There we go. If all clinically significant medication issues identified were communicated to the physician and all the prescribed or recommended actions were completed to the extent possible by midnight of the next calendar day, each time that one was identified, you would code this 2005 as yes, reviewing the whole quality episode to determine the answer. Again, the examples tell us that the clinician communicated all the issues to the physician or designee and all the actions prescribed or recommended were completed. That would be a yes. The clinician contacted the physician or designee, and the physician or designee communicated that no actions were necessary. Again, this would be a yes. The physician or designee recommends an action that will take longer than the allowed time to complete, but the agency has taken whatever actions were possible by midnight of the next day, would give you a yes answer to 2005. We're going to code this as 9 not applicable if there were no potential or clinically significant issues identified at the time of the sock rock or any time since the most recent sock rock, or if the patient was not taking any medications from that start or resumption of care through the entire episode. None. Over the counter or prescribed. The examples tell us that no potential or issues have been identified at any time during the episode, or the patient is not taking any medications, including prescribed and over the counter by any route, including TPN and herbals. The dash is still a valid response for 2001, 2003, and 2005. A dash is telling us there was no information available. Providers should complete transfer and discharge assessments to the best of their ability when a care episode ends unexpectedly. That's certainly out of your control, but you need to complete the assessments to the best of your ability when that happens. And certainly the use of the dash should always be a very rare occurrence. For 2005, your data sources are the same. Your clinical record itself, looking at the whole episode of care. Communication notes. These have many different names depending upon the EMR you're using. Some of them call it care coordination, communication notes. We all use different terminology, but they're there, and you need to look at those carefully when you're auditing that whole episode. The plan of care itself. If there were interim orders, telephone orders, short orders, whatever your terminology is, you need to be looking carefully at those amendments to the plan of care as well as the original for any information that there was an issue, a contact, and a change. And finally, the medication list, medication profile, whatever term you use, you want to be looking at that, because if in fact the clinician is keeping it current and updated as you go along through the episode, you will see any changes and be able to answer your questions 2001, 2003, and 2005 correctly and accurately. Okay, let's practice the coding one more time. Have to make sure everybody's awake and paying attention and I didn't put you to sleep. I'm really glad I'm not after lunch today. Oh, I forgot I am, aren't I? Okay. No carbs, everybody. I want everybody awake. Okay, scenario 4. During the discharge assessment visit, the RN reviews the patient's medication list and confirms that no potential clinically significant medication issues are present. In the reviewing the clinical record, there is documentation that a drug regimen review was conducted at start of care. No potential clinically significant medication issues were identified. There is no other documentation to indicate that potential or actual issues occurred during the episode of care. Using your phone or your tablet or your laptop, answer this question. Did the agency contact and complete physician or designee prescribed recommended actions by midnight of the next calendar day each time potential or clinically significant medication issues were identified since start or resumption of care? Okay, select either A, no, B, yes, C, not applicable, or a dash. Well, we're shifting a little. We're thinking about it. Okay, and everybody seems to be leaning toward not applicable. All right, we're up to 85% there. Let's go back to the slides and see how correct we were. And they were. The answer is 9, not applicable. And why is that? There were no potential clinically significant medication issues identified since the start or resumption of care, or the patient is not taking any medications. There is documentation, it always comes down to that the agency looked for potential or clinically significant medication issues via a complete drug regimen review. No potential or actual clinically significant medication issues were identified at any time during the completed episode. from start through discharge. Let's try it one more time. You're doing very well. During the start of care comprehensive assessment, the RN completes the drug regimen review and identifies a potential clinically significant issue. On that day of admission, the RN calls and leaves a message with the physician's office related to the medication issue. The physician does not return her call until after midnight of the next calendar day. No other medication issues arise during the episode, and the patient is discharged. So let's think about this one. Did a complete drug regimen review identify potential clinically significant medication issues? Using your phone or your tablet, answer this one as either no, no issues were found, yes, issues were found, not applicable, the patient is not taking any medications, or a dash. Oh, not bad. Got some second thoughts going on here. Okay, let's now go back and see who was correct. The answer is yes. Remember, the nurse did find it, and she reported it, but she didn't get a call back. Now let's look at this question. Did the agency contact the physician or designee by midnight of the next calendar day and complete prescribed or recommended actions in response to the identified potential significant medication issue? Did the agency contact the physician and complete the response? The answer is A, no, B, yes, and C, enter a dash. No? That's there we go. I think the yeses are changing their mind here. Okay. Oh my, they're really overthinking it, aren't they? Keep going. Okay, let's go back and see what the real answer is. The answer is no. The agency contacted the physician, but did they complete the prescribed or recommended actions in response to the identified issue? Did the agency contact and complete the physician or physician designee prescribed and recommended actions by midnight of the next calendar day each time potential clinically significant issues were identified since the start or resumption of care? How will we answer this one? Is it no, the actions were not completed? The answer, yes, they were. Or not applicable, there weren't any. No medications here. Okay, 3/4 of you think the answer is no. We still have a core group that thinks this doesn't apply here. Shifting a little, back and forth. All right, let's go back and see what the real answer is. And the real answer is no. Let's look at this here. The coding at start of care for 2001, the answer was yes. Issues were found during the review. Coding at discharge, for physician notification, 2003 was no, because the physician didn't call back in time. And for coding at discharge, 2005, it's still no, because during the whole episode, the issue was identified, the physician notified, but there was not a callback timely, and so therefore the actions could not be completed timely. Because an issue was identified and determined by the clinician to be clinically significant, it meets the criteria for a clinically significant medication issue, so 2001 was answered yes. While the clinician-initiated communication, the required two-way communication, did not occur until after midnight of the next day, resulting in 0, no, for 2003 and 2005. Drug regimen review conducted with follow-up for identified issues. Let's talk about the measure itself and what this is telling us. The measure is titled Drug Regimen Review Conducted with Follow-Up for Identified Issues. The description is the percentage of patient care episodes in which the drug regimen review was conducted at the time of start resumption of care, and timely follow-up with a physician occurred each time potential and actual clinically significant medication issues were identified throughout the care episode. Calculating this, we have a numerator and a denominator. The numerator is defined as the number of episodes in the denominator where the medical record contains documentation of a drug regimen review conducted at start of care and resumption of care with all potential clinically significant medication issues identified during the course of care and followed up with a physician or physician designee. Your denominator is the number of patient care episodes with a discharge, transfer, death at home assessment during the reporting period, so that you are looking at a complete quality episode. What is excluded from the denominator? Nothing. All completed episodes go in here. This measure is not risk-adjusted or stratified. What data collections items are included? We've looked at these 3 items that are included in this measure. 2001, the drug regimen review. 2003, the medication follow-up. And 2005, the medication intervention. If a dash is entered for any of these 3 items, the quality episode will not be included in the numerator count. The quality episode will be included in the denominator count. The timeline for this measure, data collection, began January 1st, 2017. CASPR reporting would appear no later than January 2018, and public reporting no later than January 2019. And remember, we said yesterday that when you look at public reporting, when you look at Home Health Compare, the measure title may not be the same as what you are accustomed to looking at, because on Home Health Compare, these titles had to be put into layman's terms so they would understand what they were reading. In summary, the Drug Regimen Review measure was adopted to meet the requirements of the IMPACT Act in the domain of medication reconciliation. The Drug Regimen Review items were first introduced to home health in 2010. Boy, does that seem like a long time ago. And they were revised on January 1st of 2017, 2 years ago. These items are now being implemented in IRF, LTAC, and SNF during 2018, so that they are now all using this item and beginning to collect data. The Drug Regimen Review guidance was refined in the manual to promote the cross-setting alignment, so that, as we said yesterday, in each of the different settings, we are speaking the same language, we are collecting the same data in the same way, and reporting it in the same way, so that when we communicate as the patient moves from one setting to another, we are able to give each other effective, understandable, reliable information. Okay, so that brings us to the end of Drug Regimen Review, and it gives us some time, which is unusual today, to actually share some of our action plan ideas. Making sure that this drug regimen review and reconciliation takes place correctly and effectively is very important. We know that medication issues contribute significantly to emergent care and readmissions. So if anyone has any suggestions, something they did that worked really well, has any questions for their peers about what they could do to help resolve an issue your staff are struggling with, I'm especially interested if anybody has some recommendations or suggestions about the one clinician rule. Do we have any hands here? No? Everybody's anxious to go get, oh, there we go. We have someone with a question, Bridget. It's like a maze trying to get through the tables.
It's not a question, it's a comment. But I have to share it because this is a bugaboo for me for the last however long it came out. And that is, our clinicians make a habit of calling the doctor right away when there's an issue. Sometimes they call a second time. I've even sent faxes to a doctor's office. I've had staff do that. And that not getting a response within that 24 hours is an ongoing issue in home care. We just made a mention of how this is being collected across the spectrum, which is very valid. It's an important thing. I truly get it. But in other settings, AL, SNFs, rehabs, the accessibility to a physician is much more accessible, for lack of a better word. So my question would be, has CMS ever considered within that question to then further specify, despite whatever attempts, there was no response from the doctor?
That I don't know, but we can,
I'm talking about within our OASIS. You are considering that?
No, what I said was I don't know.
Okay. Was that?
And what I would suggest that you do is
I'm like, look, there's a person in front of me saying yes, 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 and I'm like, I'm thinking, oh, you are?
No, everyone has raised the same concern.
Yeah, I've raised it.
And I hear that. I mean, I've been practicing in home health for, well, forget how long. I don't want to confess to that today.
I'll confess, 41 years.
Oh, well, good. Somebody who's been at it as long as me.
So I really do understand that
Right,
this is
and
an
we
ongoing
do know
issue.
that this is, we recognize peer-to-peer, we know this is a difficulty. What I would recommend to you and to everyone in the room is that you take some time over lunch, talk to somebody you've never spoken to before, ask them what they're doing, ask them what their success rate is. In the agencies that I deal with one-on-one, I hear different success rates. Some agencies are getting the response back, the two-way communication, 90% of the time.
How about we ask it right here with a show of hands?
Well, I would recommend that if someone has something that works, can we see a hand? Okay, we have someone up here that has something that works. Because that's the issue. We need to work together. If there are ways to get the communication to be a two-way street that are effective, we need to share them with one another.
Does CMS not want to know that doctors aren't responding?
What does CMS do to educate physicians for us? I mean, that's part of it. If it comes from us, it's not as powerful as if it came from CMS and said, these are the rules you have to abide by.
There are mechanisms and ways for you to express those concerns. Today, what we're interested in is how you can help one another.
This isn't foolproof, but it has helped us. We have a system called Doc Halo, which is almost like a text messaging system that is secure and meets HIPAA requirements. And many of our hospitals, the physicians are on that. And we've gotten a lot of success with sending them a message through Doc Halo, and they have gotten back to us. It's quick, like I said, more like texting. It's not 100%, it's not, but it definitely has helped. We use tablets in the field for our field clinicians, and they have the application on their tablets, and so they're able to reach out to the physicians directly.
Okay, and if I could ask if people could please raise their hand and I'll come to them, because we have people listening online who can't hear if people are just speaking.
I just want to add to that. We've had really good success if the physician will allow us to text information to them. They will respond almost immediately, so thank you for that. However, 90% of your physicians don't want to give you their cell phones.
Okay. Talk to each other. We are each other's best resource. Share the things that work, share the ones that haven't worked well. And I understand that this is a difficult issue. And I've actually, because of the work that we do that is cross-setting, we've actually heard from the other side of the coin that the physicians are frustrated because they have tremendous demands. And they're dealing with all kinds of new quality demands on them that they've never dealt with before. So we're all learning. We're all trying to function in a different world where the communication and the quality-based measures are coming to every sphere of healthcare. And we all need to work together. So talk to each other, figure out some ways for outreach, express your concerns to CMS, because certainly I can't do anything with that. That's really not my role, but you need to express your concerns to where they need to go. And we'll take it from there. And Bridget is going to take us to lunch.